Welcome to Living Vividly, the podcast where health, wellness, and curiosity collide. I'm Jackie, the founder of Vivid Health and Wellness, your guide on this journey to living your happiest and healthiest life.
My co-host Daphne, the unconventional dietitian, is always ready to shake things up and bring a fresh perspective to your wellness journey. And we can't forget Dustin, our producer, who keeps everything running smoothly behind the scenes. Together, we'll chat with health and wellness experts along with everyday people who have inspiring stories and practical insights to share. If you're ready to nourish your body, move better, and discover simple ways to thrive, you're in the right place. And hey, if you enjoyed today's conversation, don't forget to leave us a comment sharing your thoughts, and subscribe so you never miss an episode.
Today we're joined by Kimberly Thibeaux with Brain Injury Nurses of Acadiana. We're really excited to talk about this.
It's pretty much like, I started it out as like a home, kind of like a home healthy, but it's only nurses. There's no therapy team or anything like that. And going in survivors' houses and helping them through like the traditional things, like the conventional things. So we have conventional parts and then we have unconventional parts. So the conventional parts are like helping with med management, helping with organizing like case management, organizing what's going on, because with brain injury there's so many. Yes, there's so many different providers. And I mean, you have psych, you have neuro, you have GP, you have a lot of times you have orthopedics if they have, depending on how long out from the brain injury they are. So there's so many people on board. And as nurses, we even do that in the hospital, and every environment of nursing is I always look at it as like the center of the wheel. Like, you know how you have your spokes and then you have the center? Nurses really have to shine in that center, because then we kind of take from what everyone else is doing and then we bring it to the middle and say, okay, this is how we need to sustain. So
you help with the implementation part of what everybody else is.
Yeah. So let's say you have a client with a brain injury and they're so independent that they actually don't live with anybody, but yet they cannot, their carryover is poor. So then we can come in the house and say, okay, Daphne, what are you implementing for them on a nutritional level? And then how can we help you to bring it in their home? Same thing with therapy, and that's any therapy. So you have your psych therapy. I have a client that works with certain things, and then we'll kind of dive deeper, and then we go into how does that function in their life. So I like to even call it functional neuro nursing, because we're taking everything that is coming from all the different places, all the different specialties, and we're making it functional for them. How can the presentation of the brain today, because with brain injury, everything shows up differently, minute by minute, hour by hour, day by day. So how can we see the patient's presentation, and then how can we maximize the carryover?
Can we talk about just brain injury in general? So obviously there are some things that are obvious brain injuries. So, if you get in a car accident and hit your head, there's a brain injury.
Yes.
But what are some of the more common, like concussions? Tell us, when you say brain injury, what all does that mean? Stroke, concussions?
So whenever it comes to brain injury for me, and I say for me because before this, I was doing stress management coaching. So a lot of my patients had brain injury, but it's emotional trauma, it's psychological trauma. And so whenever it comes to brain injury, that's kind of where I bridged in from my other coaching business. But then I realized how much is needed from the more widespread brain injury. And you have your strokes, you have your traumatic brain injuries, you have your mild, which is concussions. And now they're kind of trying to phase out this whole mild notion, because post-concussion, you can have a lot of symptoms that last forever. And so part of what we do is also helping to minimize those minimize the symptoms and how they exacerbate by the different interventions that we can do too. And that's something that we can talk later whenever it comes to the more unconventional ways of approaching brain injury for our specialty. So you have your hypoxic episodes, whether, it's drug overdose induced or stroke or tumors, that impress upon the brain, and then it affects the brain function. Some of that area can be like cancer and things like that. So there's many different ways that you can have a brain injury, but at the end of the day, it's kind of like that common denominator. you have a brain that is injured. So now it's neurodivergent. And so
explain what that means, neurodivergent.
So you have your neurotypical brain where, you have a brain that is not impressed upon by any sort of trauma whatsoever. So it functions the way that it needs to. But if we say, okay, well, we have a neurotypical brain, I mean, honestly, I don't know that any of us live with that, because whenever you look at the environmental ways that we are impressed upon neurologically, whether that's the air, the food, the medication, the our daily habits, all of it, how we're sleeping, how we're not sleeping, all these things impress upon our whole body. And so then neurologically, it also affects how we connect with our internal environment and our external environment.
So neurotypical would be like normal, like what we have perceived in the medical world as being normal.
Yes, and within normal limits. But even
that would even be on a spectrum.
Exactly. Yeah. Even whenever you're charting within normal limits, you still have a range. And so from my world, it's more along the lines of I feel like we're all some sort of neurodivergent, but on what level? And so what is needed? So whenever it comes to the neurodivergent and how the brain is showing up, the more unconventional ways of approach is, okay, you were just given this activity to do from the doctor's office and you're not doing it. Is it true avoidance? Like, is it behavioral? Is it emotional? Is it mental? Is it physical? Like, you can't do it? Do you need modifications? So post brain injury, sometimes your survivors can get stuck in these cycles. So with the neurodivergent brain, it wants to stay in the familiar. It wants to stay in what is quote unquote safe. And so whenever it comes to survivors and they're not carrying over what they need to be doing at home, or they're not, so then it's to say, what cycle is at play here? Like, what is causing them to not do what they need to do for their overall well-being? And it's collecting all this information to then be able to help them implement it. Because a lot of times your providers only have 15 minutes with them, 30 minutes with them, and 30 it's on a good day, just because of the nature of the system nowadays. And so essentially that's where the bridge of conventional and unconventional comes in, because if you have a patient that, like for physical therapy, if they're being told do this set of exercises but they're not doing them, like for instance, the mind and body, we always talk about that in many different realms, the mind and body connection. But for brain injury, the mind and body connection is completely changed. The whole landscaping has changed. So whenever you ask that person to do a physical therapy exercise, is it because cognitively they can't count the reps, so they just get sidetracked and they can't stay on task? Is it because their interoception of that muscle group, they're not able to truly connect with it and contract that to do the exercise? And
so interoception is
being able to turn inward. And the best way that I could explain it is, your body scan meditations. So whenever you go into a meditation and you're helping people to go through their whole body, feel into your big toe, feel into your knee. So interoception helps you to connect with that internal environment. And so if they're not able to connect appropriately, then they're not going to be able to do a lot of things, and so that's safety wise, that's functionally. And so from a nursing perspective, it's important for us to go in and consistently assess, how is the nervous system presenting? How can we be in that window of tolerance? But another layer to that is assessing, okay, are they not able to do this exercise because they're outside of their window of tolerance stress-wise? Or is it because of those other things? So that's why the specialty is needed, is because from a nursing assessment eye, we're having to say, okay, how is the nervous system presenting? And what is causing the barriers and the obstacles, and how can we strategically and purposefully give the nervous system stressors that it can handle, and that can make the person be able to evolve and do more and more things and stop that cycle that they may be stuck in, that may be the safe cycle that's non-therapeutic.
So I can think of so many reasons, people where behavior change, not necessarily related to brain injury, the way that we would kind of define brain injury, but behavior change is hard because they just can't do it. For whatever reason, there's a disconnect, there's a block. I don't have the skills to assess why they can't do it, but nearly, I'd say 90%, it's probably more than that, of people that I work with in my clinic, in my practice, where they're going to physical therapy, and I'll say, are you doing your physical therapy exercises at home? No, never. And I don't work in the brain injury field. You know, I mean, that's not, I might have some, I can't even think of one person that I'm working with that has brain injury, but behavior modification is, it sounds like that's kind of what you're doing,
absolutely.
Is helping with behavior change. And that could go across anything, not even close to brain injury related.
Well, and I think what's unfortunate is that in allopathic medicine, they don't always ask, have you had a brain injury? Unless you're in a neurology office, you know, a neurologist's office, unless you just had it and it's big enough for you to put it on there. But you have your people that have concussions and are really like taken back, and then they go into the ER, they're treated, go home, rest, turn off the lights, do the traditional things, and then they have significant issues later, like they can't implement and it goes under the radar as, well, they don't have a brain injury, but they may have. It's just not on their history, and nobody's asking the question. So my biggest challenge to all providers out there is ask the question, have you ever had a brain injury? And with a lot of women, it's, have you been in a domestic violence relationship? Have you, like with men, have you been on the job? Like, and I know that these are like generalizing statements, but sometimes we have to get general to get the information that we need. We have to ask those probing questions, like, have you ever had a brain injury?
I think you'd even have to go deeper than, I mean,
like some people might not know that they've had a brain injury.
Yes, that too, of like what kind of brain injury. Like, so for someone who, let's say someone who works in a more physical field, like, okay, let's take an MMA fighter. Okay, they get, sometimes their head, or they're in sports, or they work offshore.
Let's just take a teenage group of boys that are playing football or soccer together, and one of them gets thrown down.
Exactly.
I mean, may not necessarily be a concussion where they have to go to the ER, but I mean,
those same boys might have some behavioral issues that no one really can explain. But it goes back to the football field.
That's why I called it Brain Injury Nurses of Acadiana, is because it's like really serving any brain injury. Because if you can look at the nervous system and say, okay, if I can neuroregulate and create resiliency through that, then that's where your behavior changes. That's where your cycle breakers, that's where your chain breakers, that's where you really get the maximum changes, is by tapping into the nervous system and saying, how is this person, are they able to neuroregulate? And what does that mean for them? Because each person is different. Like one time, it was very intriguing. I had this phone call whenever I was still coaching, and the woman was very hesitant about like what she wanted to. She was in a very acute state though, stress wise, and she said that she wanted to feel the way that a snow globe, right? She wanted to feel the way that the last little snowflake falls at the snow globe, and that feeling of calm and silence and serene. And so right on that phone call, I ended up working with her for a little while, but it wasn't the point. The point is to just show people that your brain can self-regulate in a matter of minutes. So I took her through a little guided imagery session over the phone, and her anger went from, or that irritable feeling went from like a 8-7-8 to like a 2-3 or something of that nature. And so within minutes, if we are speaking the nervous system's language, it will immediately tell us. And so whenever I'm working with people, that's why I say we have to consistently be assessing the nervous system. What are those signs? Are they fidgeting? Are they, getting irritable? Are they saying things that, and in the bigger brain injury sense. Like, are they saying things that are hurtful that they don't realize may be hurtful because that part of their brain was affected, but they're saying things that are hurtful because they're outside of their window of tolerance, or are they truly upset about something?
Yeah.
And a lot of times it's they're outside of their window of tolerance and they need help to regulate. And so I mean, I've seen people that are 2 to 3 years out of brain injury, and I've seen people that are 40 years out of brain injury. And I will tell you, they both have
present
huge
the same way.
huge results. I encourage people, if you've had a brain injury for decades and you find that you're having certain struggles in life, call. I offer free phone calls of like, hey, what are your thoughts on this? Do you think that this is something that you can help with? Or absolutely. Like, I offer those phone calls because I'd rather someone call me and maybe like, actually, that sounds like it may be this provider that you need. Or I'd rather them call me and get directed in the right path than just never know and keep band-aiding things.
Just adapting.
Exactly.
Yeah.
Just band-aiding things that, you know, and by band-aiding, I mean, because we have all these medicines, all these supplements, all these activities that can help, but your tool is only as good as what you know how your body's functioning.
Right.
So you can have the best tool on the block, but if you don't know what's going on underneath that, then you're just sprinkling water on a fire that you're just keeping it at bay, but you're not actually getting to the functional cause and what can be changed.
Whenever we had coffee the other day, you told me a story, and I actually sat through a neuro sculpting meditation. I'm not sure if you're familiar with that. It's really cool. You're going to like it. But they do this, like, I think it's bilateral stimulation maybe, when you're trying to change a behavior and something on the more emotional side of your brain, they will have you spell a word in your brain, or think of just like outrageous things. Like, think of a purple bunny rabbit running through the room, or the clouds are a different color, and it just kind of taps into 2 different parts of your brain, and it helps you process things better. And it reminded me of the story of one of your clients that was trying to do squats, I think. And
oh yes, so I can speak to that. So it sounds like they may be. So recently I did some work, some continuing education, and it was really cool just to tap into the nervous system in a different way, because I'm always evolving and expanding on like, how can I help these people? Because it kills me that they're actually, I've heard more times than not, we just don't do brain injury. And like
at the ER or something?
Yes. Like the day that I heard that from an ER, from a psych place, we just don't do brain injury, is the day that I went and I went on Canva, made my little logo, and I'm like, we're doing this thing. Because we are not doing our community a service if we just say, we just don't do that.
Right.
Because you don't understand it, right? And the brain is very complex. So having this conversation, that was one of the reasons why I'm like, okay, so how are we going to present this? Because it's a very complex phenomenon with very simple tools that can be helpful if used appropriately, if the stressor is at the right time. And by stressor, I mean positive stressors, because whenever you look at making changes, it's always going to be a stressor, whether it's positive or negative. Marriage, getting a new job, having a new baby, like all these things are positive stressors, but they're still a stressor. So you still have to cope with them appropriately. And so going back to what you were talking about neurosculpting. So recently I did a huge continuing education in tapping into the cranial nerves. And so whenever it comes to like aromatherapy, whenever it comes to the cognition of like doing this activity before the other activity, then it can actually help the brain, to the nervous system, to see, okay, it's safe and you don't have to focus on this injury. We can do what we need to do by firing these other muscles. And what I mean by that, so this example is, I had a client, and whenever he would do a squat, I could see like his calf muscles were very, like they were quivering, like, you know, some sort of muscle fatigue. And so then I'm like, okay, let's look at what's the next step that we can do. He had like a soft brace from CBIS or something like that. And so we put on the soft brace for tactile stimulation, for skin stimulation. Put that on, it was a little bit stronger. And this specific person is very intellectual, like decades old injury, like very intellectual, very high functioning. And so I was like, you know what? But at the same time, you could tell that there's certain lapses that that this person needs help.
So he had a lot of compensation mechanisms or techniques.
Yes. And so then the next thing that I did just to help the brain, like with the cognitive check of safety stimuli, is that we did like this puzzle is like a little, puzzle. And then that was the strongest his leg was, like barely any, like
right after doing the puzzle.
Right after doing it. So I did it within like 5 to 7 minutes. I did back to back to back because I really wanted to see, was this, and a lot of the work that I do is trial and error, right? Because we have to see what the nervous system likes and what it doesn't.
Yeah.
So if it didn't get better, then I can tell, okay, this didn't really work for him. So let's see if there's something else. And sometimes because your cranial nerves are like the direct access and tells your brain, okay, we're safe, we're cool, then using things like essential oils or some sort of cognitive puzzle or some sort of skin stimulation, it can really help the brain to see, okay, I don't need to focus here. I can focus on this muscle group that you're actively using. And the best way that I can explain why that is because post brain injury, it's like you have this, the best way that I explain it is like you have this big plug and you have multiple fibers in the wire of the plug. So whenever you have a brain injury, it can unplug. But as you heal, the neuroregeneration, and because of neuroregeneration, neuroplasticity, you have certain fibers that can connect back, and then you have other fibers that are kind of lagging because maybe you don't use that as often, like what's something like reading a newspaper or something, reading a book. It's something that's a part of, that's important for us as humans, but it's not something that you need to survive, right? But if this person is an avid reader, we need to get there to help the nervous system feel safe and in that window of tolerance because she's doing something that she loves. So that means if you're connected in life, then you're not in that hyper aroused or hypo aroused state.
Right.
Does that make sense? So whenever it comes to that connection, those fibers that are not connected, that's where our work is saying, okay, what fibers are not firing? How can we help those connections to come back and to work for this person?
So you mentioned window of tolerance. What exactly does that mean?
So the window of tolerance, when you think of stress, so many people talk about, and in a traumatic sense, PTSD or stress in general. So the window of tolerance is the amount of stress that the nervous system can handle without going into a state of hyperarousal or hypoarousal. So often we think of like fight, flight, and freeze. And I'm going to be very simplistic here. And the reason, so when you're hyper aroused, you're in that fight flight place. So that's a more extreme. When you're in that hypo aroused state, that's more of your freeze. And so let's say your everyday stressor, like you're stuck in traffic. Within normal limits, you have a little up in hyperarousal, and then you come back down into this connected like state of being present. Okay, you can laugh at a joke if you are talking to a loved one, like you're back into that regulated state.
So that's the window.
Yes.
Okay.
So the window of tolerance is like your green area where you're connecting, you're laughing, you're present in the moment, you're mindful. That's your window of tolerance.
You can get close.
But those stressors don't like get you out of the
Exactly.
I'm visualizing someone who is never in the window.
Yes. So as life happens and as traumas can occur, and I feel like this word trauma has been so diluted, but at the same time, so whenever you think about trauma, it's a level of stress that the nervous system feels that it's so overwhelmed that it can't survive through. So where a car wreck can be something, going into combat can be something, but then also your mental and emotional traumas can also be in there too.
Right.
And so it all just affects how your nervous system responds to this, like the everyday stressors and within that window of tolerance.
I said in one of our previous episodes that I heard the easiest way that I've heard trauma described was if something happens to you, whether it's a physical thing or an emotional thing, where it changes your view of yourself in your world.
Yeah. So I can kind of build off on that. So essentially it's that it's how you connect with your external and internal world.
Okay.
Because your mental self-talk, how you experience your sensations, like your, butterflies in the stomach, or where once you maybe have experienced, and going into, let's say, excitement versus anxiety. Those are really kissing cousins here. Like those are both can be in this like hyper aroused state, but one is a positive stressor and one can be a negative stressor. So anxiety in itself is one of those unique things that it can be something that works for us, because anxiety is something that we're immaculately created, and every part of our experience is supposed to be, it has a purpose. Anxiety has a purpose too. Mild forms of anxiety, on test taking, like driving.
It can be a driver to help you do better.
Yes.
Yeah.
And like if you're driving and somebody just comes out, a little spike in anxiety helps you to pump the brakes, and it's your quick reaction.
It's like a survival skill.
Yes. So we don't want to live there. And chronic anxiety, or a form of extreme hyperarousal, is where you're panicky, is like all those experiences. And
I feel like chronic anxiety would kind of live somewhere in between there. So it's it's out of your window of tolerance. It's not hyper, but so many people live kind of in
it's in the yellow area.
The yellow area.
And so going back to that window of tolerance and that area of green. So the more that we understand our own nervous system, and the more that we can get that internal language of like what's going on, and what, like for me, if I'm experiencing something stressful, I may get those internal cues differently than you. And so we have to learn our own internal dialogue language from our nervous system, like what's going on. And then the more that we learn that, the more the body feels safe, because then we can respond appropriately. And so then your green area grows. But whenever a trauma happens, even if like those of us who have been very connected in our life, we, like even me, okay, let's say, God forbid, I have a brain injury and I've done this work, I've done this research, my window of tolerance can go kaput, like it can decrease because of that trauma in itself, the nature of trauma. And so whenever you look at brain injury, even though someone has learned all these skills, if you don't have someone that's checking in and saying, hey, because a lot of brain injury patients, divorce is there because it's very difficult, because your person now changed.
Right.
And so if you don't have someone that is feeding and nourishing this person to help them in their relationships functionally, not just from a psych perspective, but from all perspectives, because the medical strain of it, there's so many different aspects. But if we don't care for that person in that way, then that divorce will shrink that window of tolerance, and then their cognition, where once they were very cognitively connected from that plug-in, their fibers can be severed again, because that's a big trauma that just happened that can throw them into regression. And so that's why whenever it comes to the agency that I opened up, it's more along the lines of, we can see people every day, all day, or we can see people once a month as needed, whatever they need, because whenever it comes to trauma, you never know what's going to affect your window of tolerance that then could affect, because you can have highly functional people that are working, they have a death in their family, and then all of a sudden that emotional trauma in itself kind of exacerbates all those old symptoms.
So it sounds like there's a lot of overlap between like a therapy, understanding the way that the body works and the way that you perceive stressors. That's also a therapy overlap, right? Where you're working with therapists. A therapist will help you do that.
Yeah. So we complement psychotherapy a lot, because with your therapist, you're going however many times you need to go, but then it's like, okay, what does that look like in your life? Like, how can we help implement those things? How can we, and I truly believe the theory of nursing is very different. So even though there's a mental health factor, your nurse is kind of like that umbrella. So while we're not psych practitioners, we do help in the way that, how do I explain this? It's more like a generalized umbrella that we can say, okay, this is what they're going through. This is how we get them through it. And in this moment, and then it's like, okay, you also need to check in with your counselor. You see what I'm saying?
Right.
Or like, so if there's like an acute exacerbation of something going on, then it's like, we are also that person that can be like, okay, it's time to go back to the physical therapist, or it's time to go back to this other provider. And we can help the family stay engaged with that too, and not put things off. And then it also causes more exacerbation, snowball of those symptoms.
You mentioned something when we had coffee, like nurses are, it's like you're supposed to love and care for them, and you're almost coming in like this maternal figure to kind of help whatever they need. And just
so one of the things that whenever I don't remember if I was still in nursing school or I just graduated, I went thrift shopping because who doesn't love a good thrift shop? And I found this really old nursing textbook from like the 1940s, 50s.
Wow.
And so I just thought it was fun because I love old stuff. I love antiques and stuff. So a textbook from that time period of like, okay, what does that even look like? There was this protocol for tuberculosis that was like greenery in the room, opening up the window for a certain time of day. So like the nursing interventions, whenever it comes to nursing theory, the founder of modern day nursing, Florence Nightingale, said it best. This is kind of what I live by. The nature alone cures. So the nature of the body has the ability to regenerate and cure and heal. And there's a whole different healing and curing is different. But anyway, so we have the ability to do those things. And she said, nature alone cures. What nursing has to do is set the body up to do that. And so the theory of nursing that I passionate about is really that is like, I know I have all like God created us so immaculately, and the more that I learn about the body, the more that I'm like, there's no denying that we are immaculately created, and how just the compensatory mechanisms to survive, and then the regeneration ability of our body. But yeah, so whenever it comes to the way that we approach it, it's least invasive and environment external to internal, and vice versa. What lit me on fire was actually another local nurse. She's amazing. Miss Jill Loracini. She actually taught at UL a complementary alternative medicine class. And whenever I went in that class, I was like, yes, this is my jam. This is where I am. And I just never knew where that would take me. And then, after graduating, I actually went back for naturopathy. So I did a lot of classes going to, be certified as a naturopath. But then whenever it came to the logistics of it with my nursing license and everything, I was like, let me just stick with nursing. And because I really love the theory of nursing, I love how nursing, we also have such a spiritual aspect too. And so it's more holistic and all encompassing for me. And so since then, I've even done yoga teacher training. I've done acupressure training. I've done cranial nerve training, brain injury training. So, nurse coaching. And so I feel like all of it has kind of set up this beautiful garden of leading me to brain injury. And I didn't even know that this is where I was going.
Yeah.
The window of tolerance.
Mm-hmm.
It feels
stuck on the window of tolerance.
I love this term. It's such a cool term.
It's really good.
I'm going to use
really
it in everyday conversation.
Yeah. Are you in your window of tolerance?
You are outside my window of tolerance.
I do that with my kids. I'm like, are you in your window of tolerance? Because it sounds like we need to work together to neuroregulate together, and co-regulation.
Oh my God.
needs to
My
happen.
kids would just flip out. They'd be like, that's enough.
Yes. I can see Alex's eyes.
My poor children. No.
Window of tolerance. So bigger at some points, smaller at some points.
Yes.
So what's a quick version of what it looks like when you're outside your window of tolerance?
So
or it could be a lot of things.
Yeah. That's where your anxieties come in. Okay. That's where if you're feeling
your uncontrollable
yes,
reaction.
the symptoms of your nervous system is telling you. You may be short of breath. You may have a lump in your throat. All of these things your body's saying, okay, I'm a little heightened here. Something's going on.
So earlier you said whenever you have traffic or something bad happens and you get a little bit aroused and you go back down, being outside of your window of tolerance would let destroy your day, and now you're fighting with your spouse.
So basically your nervous system is snowballing. Like it's just getting bigger and bigger and bigger and bigger. And so that's where neuroregulation comes in. So whenever
you can bring it back.
Yes. So whenever it comes to regulation, you have upregulating and downregulating. Because if someone, let's say someone's in freeze, we don't want them to just like, let's say, sit in meditation for that may not be therapeutic for them.
Right.
So then it's like, okay, well, how do we get this person out of freeze? We need to upregulate. We need to give them some sort of movement and activity, and but therapeutically speaking, because if the body and brain isn't ready for it, then it's kind of like you're giving them a tool that's not speaking the language that they're in. So the beautiful part, and I'm somebody who I love to create, no matter if it's art, professionally, whatever, like in my professional field, in my personal field, cooking, everything, I love to create. So whenever I'm talking to a patient or whenever I'm in session with a patient, I really listen for those powerful statements. Like what are they speaking to me? And then from those statements, I can gauge like what is the mapping of their nervous system, like what's going on, and then what are the tools that we need? Because sometimes, it may be one of those tools of like deep breathing, or it may be a tool but sometimes it's like they need brain stimulation, they need cognition, they need something that is difficult, like a challenge, a healthy stressor, a healthy challenge.
How do phones and I'll say like addiction to phones, how are you seeing that in your patient population? How is it reflected in
I'm
your
sure
population?
with someone with the brain injury is worse.
So, and oh God, this drives me crazy. And then it's like whenever
Stay in your window.
Well, it's whenever, yeah, exactly. Stay in the window of tolerance. Okay. So, and it's like nowadays you have these apps that are like, oh, well, let me help with your cognition, or so at the end of the day, that's where the Band-Aid comes in. At the end of the day, if you're doing a puzzle on your phone, it can be good, but then to what extent? Because also you have the blue light, you have the visual stimulation that is just boom, 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 boom. And that can cause brain exhaustion and fatigue. And then whenever you have a brain that's fatigued and their brain battery is done, then you have increased exacerbation of symptoms, whether it's internally, whether it's behaviorally, whether it's emotionally. You have it's literally like tantrums because the nervous system is outside of its window of tolerance. And so whenever it comes to caffeine, like I'm no fun whenever it comes to caffeine, because caffeine is very stimulatory. So whenever it comes to sugar, caffeine, and sugar's another thing that is very difficult, because with brain injury population and honestly with the aging population, glucose is something that it's so simple for the brain to run on, even though it's cheap energy. It's very cheap, but it knows that you get that high of blood sugar and you're like, oh, I'm here, and so with our brain
Are you saying
injury,
it's a bad thing?
Yes and no.
It's non-sustainable.
Yes. Like I kind of don't go to like the good or bad. It's more along the lines of like this gray spectrum, right? You don't want to have somebody who lives off of sugary stuff because they know it's easy energy for their brain. It's not going to sustain them. So like if you know somebody, Maslow's hierarchy, if you know somebody is truly hungry and they won't make it to that next meal, or you're out on an outing and they have a brain injury, like give them a little bit of something that is going to help them through to where their window of tolerance, that cascading doesn't keep happening. But it's a quick fix. And by, I mean healthy ways, not, your high processed food, because that's also another thing. Like if we can't read it, then our body can't process it. And if our body can't process it, it can't use it appropriately. And that's for our brain as well too. So if we clean up those things, then we can function better. And caffeine as well. It's kind of like throwing that fluorescent light back out there. It's like the brain is just stimulating because it's heightened on caffeine or sugar, and it's just stimulating even if it's not stimulating appropriately. Like I've had a patient that I've never seen this person with caffeine, and then all of a sudden came to the appointment and just like so distracted, not being able to and it wasn't necessarily that person was suffering because she was in a very good mood, but you could tell that because of that caffeine, the firing was not as appropriate. And so it messed up the cognition in the way that it needed to, and like the way that the brain needed to fire.
We've seen Daphne like that before.
I was going to say I had 2 cups of coffee on Sunday
Yeah.
and cleaned my whole house.
See, it can be productive,
done.
but no, but like with the brain injury brain, I always try and steer away from like your high sugar, high caffeine.
And sugar you're right, it's cheap energy, but it's very non-sustainable because
Yes.
blood sugar wise, I mean, your blood sugar is going to be going up and down. It takes
then
that's going to
very
affect your
short
mood.
periods of
And
time.
I was about to say, and then what is a sugar like plummet?
Yeah.
What are the symptoms?
Brain
you know,
fog.
Do you
and
always
then,
sugar plummet after you eat a lot of sugar? It's a weird way to
most
say that, but
people would. I mean, depending on if it's like just pure sugar or
if you're
it's-
dressing it,
Yeah,
like
if
with
you have
proteins
something
and-
like if you have
Like if-
dessert after a meal, that would be
That-
different than if you had
that would help
just,
the meal.
Right, the meal will help you from
Right.
Regulate your blood sugar.
It'll keep you from spiking and
If you
dipping.
start your day with a donut, you're going to have
and
a crash.
coffee, you're
Yeah.
like
Yeah. You're
your
not gonna feel
adrenals,
good.
everything is just going to be on fire. But yeah, so with your brain injury population, that's very important too, is educating from all these different rounds and like realms. And that's where it comes in of like back to the wheel, is like this practice is really like that center of the wheel, because I have no knowledge to the extent that you do. Just like I know I stay in that realm of like wellness, but if there is something that is needed past wellness, then it's like, okay, you need to go back to the physical
You're like the
therapist. You
bridge
need to go
between-
back to
So it sounds like
exactly.
you're as much a patient advocate
Yes,
for all
absolutely.
of the different
and that's where case
therapies.
management comes in.
Tell us a little bit more about like your practice. So you're a nurse, but what does it look like? So if I have a patient or a family member that I feel like needs help, what does that look like? I call you and you do an assessment and like walk me through that process.
Okay, so the day-to-day, whenever it comes to referral, so with brain injury, it can come in very different fashions. It can come right after a brain injury or it can come decades later. So you may get the person that's more decades later. So that person, they can just call, and I normally do like a free conversation with people just to gauge if like where they're at, what's going on, and see if I'm the right fit for them. Because that's part of nursing too, is like I'm not going to take on anyone that I don't feel could directly benefit from our care. And then, but whenever it comes to your brain injury survivors that the disease process just happened, you know, I try and network with a lot of the personal injury lawyers, with your physicians, with just so they know that it's out there, because at some point insurance stops paying for, you know, certain therapies, certain home providers. And so we do accept HSA and like those things, and
But you can't bill insurance.
but we cannot bill
Traditional
insurance
Okay.
because the way that insurance is created, the things that they cover, it's almost like this person should still be in a rehab, like in
It's for a very
facility.
specific thing.
Yeah. So unfortunately, it's like at this point, I don't think insurance is caught up to where we need it to be.
Yeah.
Whenever it comes to coverage and what that looks like for brain injury patients, because brain injury like survivors, it's chronic. Like long term.
And you can't live in a rehab facility and
No.
live your life, but we're like abandoning so many people.
Yes.
And how many people with brain injuries end up on the streets or criminals or all these things?
I want to
when
say
they-
it was something like 70% or so. I forget. Maybe that sounds high. But I remember I was doing a lot of studying and of the statistical analysis of like where,
gonna look it up.
looking at
What is the percentage of people that are
like with brain injuries
With
that
brain
become like
that homeless or incarcerated. It's a pretty high number. If and that's where this comes in, of like helping people stay at home with their people, like helping people to sustain those relationships, to sustain their way of life, to increase their well-being. But going back to the referral process, so like if they are done with something like home health and they're getting discharged, like then they can send them to me of like, hey, this person still needs some assistance, but they're not necessarily appropriate to get approved for more home health of something of that sort. Or a family member can call and just say, hey, my loved one had a brain injury years ago and this is what we're going through. Do you think that this is something that can help?
And so you would meet up with them. I mean, I know you said it could be every day, all day, or just kind of sporadically, and that's just based on whatever kind of assessment you do?
Yes. So the phone call is really just gauging where they are. And then because just from having a conversation, I can pretty much gauge on what that person's going to need for their frequency and hours, just because of their level of function. And then we kind of like fine tune it after they're admitted, like during their admit assessment and what that care plan looks like.
And so admit, you're meaning admitting them into your program,
yes.
not like admitting them into an in-house.
No, yes. Admitting them into within the agency. So yeah, so that's what it looks like is, different providers in town, or like I said, depending on family members, if they see that, hey, this person had a lot of concussions in high school and all of a sudden they've just changed who they are, then it could be from an old injury.
Yeah. How many nurses do you have on staff?
So right now it's just me.
Okay.
But as everything, because I just opened up in February.
Okay.
So it's still a baby business, but we're growing. And so as we grow, I of course will be looking for nurses that can complement all of these things, really be strong in their nursing practice, because that's what it takes. Brain injury, it takes a lot of it takes a lot of creativity and strong in your practice to where you can advocate for them and you can practice on your own.
Studies suggest that about 60% of incarcerated people have a history of at least one traumatic brain injury.
There you go.
That's devastating.
So yeah, those are some big numbers.
Yeah, we're just throwing these people to figure it out themselves, and it's such a disservice.
Amongst all the homeless people they surveyed, 70% of them had the injury before they were homeless.
Yeah. And so that's like our goal, is to keep people functioning the best way that they can.
I think probably I would have to assume that one of the big hurdles is the disconnect between how someone is acting and behaving and recognizing that it's tied to a brain injury.
Versus just they're a bad person.
Right, they're a bad person
misbehaving.
or they're unable, like they're just I don't want to say it, like they're just dumb, they're just incapable of, so being able to make that connection.
Well, and socially, it's like I've seen, others, and I mean, we live in such a distracted world nowadays. It's like, oh, well, this is just them. This is just their quirk.
Right.
And honestly, there's a lot of suffrage that comes with that. Yeah. Like, I mean, one of my clients, it's like the simple things in life that we don't realize that it gets our happy hormones flow in, like cooking yourself a meal. Yeah. Like the other day I did it with one of my clients of just cooking him a steak. Like that simple, and, or getting new furniture, or like just realizing you need to clean out your fridge after so long. Like this person, people can live independently, but if those social or functional cues aren't there, then they're surviving. Yeah. Of course, they're surviving.
So what do you think we need to do to enhance the understanding of brain injury?
Like in society in general?
Yeah, just society-wise, like to be able to make connections that this behavior might be because of this past brain injury. How can we, like, awareness of brain injury?
And I guess it starts with the awareness of just, okay, I had a brain injury. Like I had concussion. Like, so then it's to say, okay, just like whenever we do labs on people's blood sugar and stuff, like there's signs there, but unfortunately with the brain, you don't always get that. And for me, that's kind of my labs, is having a conversation and collecting that data of like, okay, they had X, Y, and Z that happened way back when. Okay, there's some association that can be there. Yeah. And what throws it into an even more unique place is, depending on when the brain injury happened, can also affect. You look at the stages of development. So if a person had an injury as a teenager, then behaviorally they may be presenting in certain ways. Even though this person is a grown person, they may have certain, and so And I'm sure in the psych realm, there's many different diagnoses that can come of that. But is it because that person is organically experiencing that, or is it due to the brain injury? And I'm wondering if that's where we don't do brain injury came from, is because brain injury does have a complexity to it. So then it's like, it's approaching the nervous system in a completely different realm. And that's where I think nursing practice and nursing theory beautifully approaches that, just because it is holistic, it is all encompassing, and it is coming from a place of, like I said, wellness, to where we can educate to a certain level and we can help implement to a certain level whenever it comes to all of our providers. Because a lot of what we do too, if a physician says, hey, you need this type of treatment, our nurses can do that too. So we take orders from the appropriate providers. And like if they go to therapy for a certain amount of time, let's say they go to speech therapy for a certain amount of time, we're there collaborating with that speech therapist. Okay, what is the long term? Like, what do you want them to sustain? Like, what activities do they need to keep doing to keep this level of wellness? And then if we see something acute happens and they have a decline, then we can say, okay, we need to go back to X, Y, and Z. And so that's where I think the awareness is just saying, okay, I understand that I had a brain injury. Let me have a conversation and see if that could be something that could be affecting my current daily life. Like I was talking with a friend, and she said that her friend had a brain injury a long time ago, but she's still working and doing all these things. And then all of a sudden she was like, sometimes she'll be talking and she'll say like a random, like something that is off the wall. And so this person, it's kind of like that slow burn. And those people are who I would like to see, so we can prevent it from snowballing further, and so we can get the appropriate regimens, the appropriate things. And look, I'm a lifetime student with anything with the brain. I mean, with the body in itself, it's a lifetime student, and it's trial and error, and understanding it with reverence of saying, okay, I deeply respect these systems. So while I'm going to do trial and error for the best interest of my patient, I also have to call a spade and say, okay, like what is really going on here, and what are the outcomes that are possible, right?
So recognize the limitations.
Yes.
I think I read somewhere that what we know about our bodies is just like less than 10% of what there is to know. So we're just at the beginning of, especially the brain, because it's not like you can just look in there and see what's up.
Exactly. And that's what's so intriguing to me. And I think professionally, that's why I ended up coming into brain injury, because it's like, I love that it's always challenging for me. I love to get creative. I love to say, okay, well, why is this happening and why is this happening? Because where a session we could be talking about one thing, it could go somewhere completely different, because that person's presentation is like, they say one thing and I'm like, that could actually be the root cause. Let's go here.
Before we let you go, we ask all of our guests one very important question, and that is, what does living vividly mean to you?
So in the nature of where I come from with brain injury, I would say living vividly would be being able to understand our body's language, because then you have the greatest opportunity to live vividly, because then you can choose.
Thanks for listening to Living Vividly. If you enjoyed today's episode, please leave us a review and subscribe. We'd love to hear from you. For more resources and details from today's discussion, check out the show notes. Until next time, keep living vividly.